Let's talk about heart failure, and this is going to be from the intern perspective. So it's assuming you already have a pretty good understanding of physiology. So let's get started. So here's a very classic presentation of a heart failure exacerbation coming into the hospital. And I'm not going to read through the whole thing, but what do you notice? You notice that he's describing symptoms of PND, right? Paroxysmal nocturnal dyspnea. Um, he's also having some swelling in his extremities, some dyspnea on exertion. And when you inspect him, he has JVD, bilateral crackles on auscultation, as well as an S3. What does all of this mean? So you know that elevated JVP is a fluid overload, right? It's associated with right-sided heart failure, which leads to an increased backup in the venous system, and that's why you see distension of the jugular veins in the neck. Okay, what else do you notice here? Uh, Okay, so these are pretty common findings, right? But what else can patients present with, right? That's not noted here. Cough. Cough is a pretty common uh, symptom, right? That you have pink, frothy, or rust-colored sputum. Some people can also have abdominal distension due to fluid overload. They can also have hepatojugular reflex. Okay, let's talk about S3. Like, why does S3 happen? Why do you hear an S3? When the ventricles dilate, and they are stiff and they become less compliant, they have early filling and they requires more pressure. The early filling requires more pressure, and that leads to increased turbulence. And that's what produces the extra heart sound during diastole. It's because of reduced ventricular compliance and elevated filling pressure. Okay, I'm going to move on now. So, what do you order as an intern? Okay, as an intern or resident? First, you always need to get a thorough history and physical, right? Chest X-ray. What do you expect to see on chest X-ray? Okay, you should expect to see pulmonary edema, right, due to elevated pulmonary venous pressures, secondary to the left heart failure. The fluid from the leaky capillaries floods the interstitium, right? Okay. What else do you expect to see on chest X-ray? A boot-shaped heart, right? Enlarged cardiac silhouette over 50% a cardiac to thoracic ratio, and that usually means a right ventricular enlargement. Okay, so that's about it for chest X-ray. Now, you'd get an EKG. And why would you get an EKG? It can provide you reasons why the person is in heart failure. So if you see ST elevations, maybe they're having an MI, and maybe the heart failure is secondary to ischemia, right? You always need to ask the whys. It's not just management, right? You have to understand why something's happening. So an EKG can provide you information such as ischemia, left ventricular aneurysm, if they have abnormal P waves due to dilated left atrium, conduction delays. So this can give you a lot of information, but especially in the case of MI and left ventricular aneurysm. Okay, BNP. Now we know this. We know it's right. BNP to be elevated, but what can it be falsely elevated in? Okay. It's falsely elevated in patients with kidney disease, patients who are older age, and patients on Entresto. Do you know what Entresto is? Entresto is sacubitril valsartan, and it can be elevated in these patients. And for that reason, you might want to get a pro BNP instead of a normal BNP. Pro BNP is actually more reliable for this reason. Another question: who might the BNP be falsely normal in? It would be falsely normal in obese people. Actually, obesity causes a falsely normal BNP. Okay, and I'm going to assume you know why BNP happens. The ventricular stretch, as a result of volume overload, causes the release of BNP, but it's a compensatory mechanism to promote vasodilation and diuresis. Okay, so now you know that. So now we want to order an echo, right? We're going to order an echo, and this can tell us if the person has a preserved or reduced ejection fraction. And this is important, right? This is important for not only documentation, but for management as well. Uh, you can be able to tell why something's happening as well. So if you have a problem with the left heart, you can ask why. Why is there a problem with the left heart? Maybe this person has aortic stenosis leading to poor systolic function, right? Maybe they have mitral stenosis, which leads to a decreased end diastolic volume and backup into the left atrium. Maybe they have aortic mitral regurgitation. So these are all things that the echo can tell you. Okay, and the other order, it's part of the order set, right? Your daily ins and outs, and this needs to be strict monitoring of the daily ins and outs because you want to know if your management is working. Body weight monitoring is also required for this because you want to make sure that the person is losing weight, fluid weight, as a result of the therapy. Now, what lab findings might you see? And I ask this because it's a pretty common pimping question, right? Some lab findings you might see are hyponatremia, especially in like acute reduced ejection fraction, because these patients have low renal perfusion, which essentially means that the renin-aldosterone system is being activated and vasopressin as well. And so you're having a lot of salt and water retention, and that's leading to dilution, and that's why you'll see hyponatremia. Some other things you might see elevated, troponin. Now that doesn't always mean ischemia, right? Unless it's really through the roof. You can have some elevated troponin just as a result of heart failure. LFTs, right? You can see LFTs, creatinine. You can see. Okay, that's about that. Oh, another thing, people with hyponatremia actually have worse outcomes. So how do you treat it, right? You need to discontinue the offending medications, okay? So what are the offending medications? Non-dihydropyridine calcium channel blockers like verapamil and diltiazem, right? Also PDE5 inhibitors, okay? And pioglitazones, okay? Treat for diabetes. So those three are really the big ones you want to look out for. Again, non-dihydropyridine calcium channel blockers, rapamycin, also PDE5 inhibitors, and pioglitazones. Fluid restriction, typically about 1.5 liters, could differ based on the hospital. Low salt diet, about 2 grams, again, differs on the hospital. If hypoxia is present, you give them oxygen. And what hypoxia is defined as what? It's usually 90%. If they are 90 or above, we typically don't give them oxygen. Okay. And as far as loop diuretics, what's the starting dose? Let's start with that. For a patient who's never been on loop diuretics before, starting dose is usually like 20 to 40 milligrams of IV Lasix or furosemide. Okay. If you want to use torsemide, it's 10 to 20. And if you want to use Bumex or bumatinide, it's 1 milligram IV. Okay. Give them every 12 hours. But if you need to, you can increase it to every 8 hours. Okay. Now, what if they are already on loop diuretics at home? So if they are already on loop diuretics at home, then generally just the initial dose will just be at least 2 times their home dose. Okay. So if they're receiving 40 furosemide at home, the initial dose will then be 40 to 80. Okay. IV 40 to 80. Okay. What else to mention here? Okay. You want to monitor for creatinine, right? If their creatinine is getting too high too quickly, you'll want to wean off of the loop diuretics, or just use less of it rather. Okay. Now vasodilators. Nitroglycerin is typically used when loop diuretics are not enough to reduce preload. And you can use nitroprusside in patients who have really bad hypertension. You got to watch out for cyanide toxicity, though, in that case. But interestingly, vasodilators have not been shown to reduce mortality, but you'll still find people using it. Inotropes, dopamine, dobutamine, milrinone. These are especially useful for severe exacerbations. Okay. And for documentation purposes, right? Here is the acute, you can just read this slide, but HFrEF, HFpEF, some acute, chronic, acute on chronic, uh, heart failure with improved EF, heart failure with moderately reduced EF, and as well as the New York Heart Association classification. It depends on the hospital if they use this, the NYHA, but the documentation is really important and you'll get in trouble for not using the right ones. Okay, so guidelines for outpatient care. Now, this is not in the hospital. Um, I like to use the mnemonic bars, beta blockers, aldosterone antagonists, RAS inhibitors, and SGL2 inhibitors. Okay, so as far as beta blockers go, which one does not reduce mortality benefit? Okay. Metoprolol tartrate, right? Tartrate. Succinate does, but tartrate does not. Okay, as far as aldosterone antagonists, there's some new data about a drug called finerenone. Okay, and what do we know about this drug? Um, I believe it was called the Fine Arts trial. And patients receiving this drug had a lower rate of acute heart failure episodes than those receiving placebo. Okay, so it's a rather new drug, but it is being put in the guidelines. Okay, so it's a part of that mineralocorticoid antagonist drug class. RAS inhibitors, neprilysin inhibitors. So we're talking about Entresto here, right? Sacubitril, valsartan. You ever wonder why Entresto works? It's an ARNI, ARNI, angiotensin neprilysin inhibitor. Neprilysin breaks down natriuretic peptides, and we know natriuretic peptides to be a compensatory mechanism, right? So if you inhibit the breakdown of them, you have more vasodilation, okay? And valsartan, we know, is an angiotensin 2 receptor blocker. It's in the name, ARB, okay? SGLT2 inhibitors as well. So these are like the big four everyone was taught in medical school, right? Some other drugs used to reduce hospitalizations but not mortality are hydralazine and nitrates. Interestingly, they are found to be equivalent to ACE and ARBs in which population? African Americans, right? Okay. So they do reduce mortality in that population, but not in others. Ivabradine, digoxin, Prisiguat, right? But those are just some other drugs that are used, not too commonly anymore. And we'll want to avoid non-dihydropyridine calcium channel blockers and HFrEF, okay? Because we know that to exacerbate it. Patients with iron deficiency anemia, IV iron drug therapy as opposed to PO intake has been shown to be helpful, and there's no benefit to anticoagulation in patients with heart failure. These are some advanced therapies. You have cardiac resynchronization therapy, otherwise known as biventricular pacing. Those are the indications, and ICD. Those are the indications as well. It's pretty much all you need to know for inpatient management of a heart failure exacerbation. Of course, I didn't go into a lot of physiology here, but I did hit some of the higher points on some of the nuances here.